We shall now go on to our second speaker, Dr. DEEPTHI MEDA, who's a director and consultant of cornea and refractive surgery at Karthik Nethralaya, Bangalore. And she is going to throw light on corneal tomography, the key indices for refractive screening. On to you, Dr. DEEPTHI.
Thank you. Thank you, Chitra ma'am and ARC for this wonderful opportunity. So yeah, I think this is a very important topic for every corneal refractive surgeons as to what are my key indices when I want to do a pre-refractive screening. Because when you're speaking of keratoconus, it's totally different. We are looking at gross numbers, but it's very important to look at early signs of FFKCs when you're doing a pre-screening. So through this talk, I'll just explain the key indices which I look for, and it'll be mostly on the Pentacam because that's the device we use. And I'll end it with few case presentations where probably a few practical tips on reading topography. Now we know Pentacam is huge. What we max give is a printout to a patient, but there's so much more you can explore and do. But I think two important prints is what the patient usually carries out. One would be the quad map and the other would be the PAD scoring if you have the HR. So before interpretation, I think for any scan you do, you will have to mentally divide into not missing, looking at any things to look at in the Pentacam, and when in a busy do justice and line value there. So this is the first thing generally we look of any tomographies. You can see the back surface of the cornea. So these are the numbers to remember. I won't go into the technique of anything. It's just going to be the figures. And anterior elevation, you need to ensure it is lesser than 15, and in the posterior it should be lesser than 20, and 3 microns lesser than this would be borderline. And one thing important here is we are speaking only of central area, so maybe around 5 millimeter, 5.5. In the periphery you will always have values much higher than this if you are looking at a saddle pattern in a toric cornea. So when you look at your curvature maps, it's not only important to look at your K reading, but studying the pattern is extremely important. So I would just divide the patterns. This is what all of us know and see. So there are 4 things to look at when you're looking at your sagittal map, and that is the symmetry, asymmetric patterns, skewed, and special patterns. So depending on the pattern, you need to look at few things. Now the round, oval, and symmetric bow tie are the symmetric patterns. So here you look at the if it's symmetric, you know you're safer, and if your K max is less than 47.2, it's okay. Anything more than that is suspicious, and more than 50 certainly is abnormal grossly. And these 4 are the asymmetric patterns. So when you have a superior inferior asymmetry, 2 things you need to look at is the superior steepening should not be more than 2.5, and if it's an inferiorly steep cornea, it ideally should not be more than 1.5 diopters. Now the next set of patterns is the skewing, where there's a degree between your prime meridian, and something more than 20-22 should arise a suspicion that it's an abnormal surface. And then there are a lot of patterns which have been described, but these are generally after the irregularity is pretty significant and there's a keratoconus. Very unlikely to have this in early FFKC, but these are the patterns again you have to be aware of. One important pattern is the vertex pattern, which again could be an early sign which you'll have to look at. So that's the same, and this is how the same patterns look on the Pentacam. Now the next thing you look for after the curvatures and elevation is your pachymetry. So as refractive surgeons, we know we are always looking at the thinnest pachy, because most of us do have a cutoff of 470 to 480 when you're doing surface ablation. But more so than that, it's important to look at the distribution of the pachymetry. So whenever you look at the pachymat, it's important to look at the 4 mm zone and look at the superior and inferior pachymetries, and this should not be less than 30 microns at the 4 mm zone. So that is important. And also do note another value of the thinnest pachy, that should not be less than 10 microns to the central pachy. And all comparison with the other eye is extremely important. The thinnest pachy between both your eyes should be not more than 30 microns. So you also do have this keratoconic indices which the Pentacam provides. So basically KC indices are from the era of the Placido. They basically derive from your surface scoring or surface irregularity. There's no consideration of your posterior surface or pachymetry. So I do take it with a limitation, but yes, looking at all of these being wide reassures that it's all fine. you really don't have to by heart, because the pentacam gives an yellow scoring for borderline and a red scoring for your abnormal keratoconic indices. And next, very important talk of last few years has been the BAT. So we all know how the Bellin-Ambrosio scoring is done. So what we look at is the final D, and that's basically an amalgamation of all these 5 Ds. So again, here you really don't have to by heart. There is color coding, which is very accurate. So anything more than 1.6 standard deviation, the machine is going to give a yellow background, and then you have a red. So again, it's, I think each of us have our discretion how to go about. Red certainly is a no for refractive surgery. Yellow, again, I think we'll have to look into what are the parameters which is causing it yellow, and either you plan for a surface ablation, things like that. Again, beyond the scope of today. Now, these are the two indices which has been a talk on lot of research publications, that is PPI and ART, and they have been quite sensitive in picking up early FF cases. So I just want to elaborate this one concept of progressive maps in the pentacam. So if you look at the left side is a normal cornea, right is a keratoconic cornea. So all these pachymetry indices depends on how quick or how slow the central thinnest point becomes towards the peripheral thickest point. So as you see in the left side, the change in the thickness will be lesser, and the right side, because your periphery is thick, the change from thinnest to thickest will be quicker. So I think it's a very interesting concept, and this is the same at 2 mm, 4 mm, 6, 8 mm. You see how the rapid change of pachymetry happens. So based on this, you have the PTI, CSTP, and also the progressive index calculation. So it's very important to ensure your progressive index is less than 1.2. Again, ART max has been spoken in lot of research as to be a parameter which can pick up very early disease, and anything ART max cutoff would be 339, 339, and an ART average of 427. You should consider it as abnormal. So now the indices, what I said is basically looking at the pattern, looking at the numbers. I think even a good optometrist can do it if you give him a printout. But I think what is more important is how do you use these values in real life. It's not so simple. You look at values and you say your cornea is normal or abnormal. So probably the next 4 to 5 cases I'll be showing, there are scenarios which really made us think beyond looking at just the indices and the numbers. And again, an example to show we'll have to holistically look at, and not only the indices. So this is case 1, a 30-year-old lady who had stopped contact lenses 10 years prior to the pre-workup, and this was a refractive error. All the maps look okay other than this highly irregular tangential curvature, superior steepening is there. So just by stopping the contact lens, we see how smooth contact lens for the further 2 weeks shows us how much smoothing is achieved, and after another 2 weeks she was much better. So it's very important when we are doing pre-refractive screenings, as many of our patients would be on contact lens. So our standard advice of 1 week or 2 weeks may not be apt for all, because there are a few corneas which may take a little more longer. So we should not rush and look at one abnormal parameter and indices out of range and deny the advantage of LASIK. So any contact lens users, if you feel there's only a surface steepening, always do stop your contact lenses. So when I speak of warpage, this is just to show how severe the warpage could be. So this was a 60-year-old gentleman who came for cataract assessment, and we did pentacam as he was opting for multifocal. So you see the posterior and pachy are fine, but there's a certain flatness, extreme flatness in the center. He had not undergone LASIK. So after 3 days, you see the cornea has gone back to normal. So what exactly happened here was, it was a flaw in our protocol. So the technician had done a contact A scan, and then after half an hour or something had done a pentacam. So you see a huge flattening of 6 diopters just by doing a contact A scan. So it's not only the contact, but also probably the epithelium might have been a little irregular, which causes lot of disparity in optical devices like pentacam. So again, a holistic approach is extremely important. So always remember, cornea has memory, and always scan an untouched cornea. So the second case I put across again looks certainly abnormal. You have steepness, you have to a very thin cornea spot at this point. So is it in the back everything is red? So this was actually a maculonebular grade scarring at that area. So again shows that clinical correlation is extremely important, and many times there can be a small adenoviral scar that you're looking as an abnormal topography, and you would not want to deny a patient of a LASIK because of that. So always correlate clinically. So the next case, this was a
1
patient.
minute remaining.
Okay, I'm done. So this was a patient who came. He had brought a Placido-based scan, and he was diagnosed to have keratoconus elsewhere and denied of LASIK. So this was his refractive. I think I'm looking at the right eye. He had a 5 diopter with 0.5 diopters, but somehow is not convinced because he didn't have a split or anything, no scissoring, and that is a key parameter we considered. And also on the topography, the sills were 2.8, whereas his acceptance was 0.5. So when we did a tomography, a pentacam, certainly an abnormal looking cornea. But what was different was the steepening was more inferior, but the thinning was more superior. So again, is it a scar? There was no, it was a very clear cornea. And could it be a movement of the eye? Again, pentacam says no, because the QS is quite sensitive to fixation errors. So if the patient had moved, it would have not said okay. But then again, still not convinced, and we went deeper looking. So this is a photo of the keratograph where you can actually see where the Placido images happen, and certainly the patient is not looking at the light, he is looking somewhere up. And the reason for this is because the fixation is not good. So either the pentacam Q has not picked, that is because this is not a fixation of the patient error. Patient has been fixating well, but he has a parafoveal fixation. So because of that, the eye is rotated eccentrically. And also in the pentacam, you can see the fixation when you go to the overview map, and whenever you have doubts, you can always see if your patient's fixation is good. So obviously when your fixation errors are reduced and your topographies look much more smoothed. So it's very important you have your entire team understand your refractive, because these are how our devices look, and it's very confusing to the patient, especially in pre-LASIK when you're doing back on back scans and such errors can happen. So it's important you show them what you're doing, educate them well, and then go ahead with the scan. So I'll end my presentation with this last presentation. So this was a doctor's son who was interested in LASIK maybe a few years back. So when you look at the BAD, certainly I would not touch this eye if I'd considered only BAD. But when I look at the quad map, it's a perfectly healthy eye, and 568, a very keen interested boy for LASIK. So we just digged into his eye a little more to see why is this abnormality or disparity between BAD and this. So then we noted the AC depth was very shallow, and that made me think I should go and have a look at the white to white. So the white to white was very small. It was a small cornea. So it was around 10 clinically and 9.78 clinical, 9.7 on the pentacam. So when you look back at how the BAD scoring happens, or how does the machine say abnormal, normal, you'll say it is based on a normative data. So obviously a small cornea, everything is much more crowded and does not fit into your normative data. And then I got into so many papers which did say that your BAD is not accurate when you have an abnormal sized cornea. So that gave us much more confidence. We went ahead with LASIK, and he's doing perfectly fine, I think 3-4 years back. So it's very important whatever technology you use, you know in depth about how your normative calculations happen, what is good and what is wrong according to the machine, and take your decision. So I think I'll skip this one last case, and I think my take-home message would be, yes, the indices are extremely important. Anything abnormal we'll have to see, but I think it's equally important whatever machine we use, understand it in depth. Don't go by a single printout. There's so much more every machine can offer. Keep your mind open. There's always this out of the box, and always clinically correlate. And in refractive surgery, the mantra is always, if you have any doubt, one parameter, I would say wait, hold on, reassess after a few months, and then take a decision. Thank you so much.
Very nice examples, Deepthi. You actually brought it all. So then in link with what you discussed in your third case, so if there is a focal inferior superior asymmetry, how would you differentiate it from a decentered apex syndrome?
Yeah, I think that has been the talk of a lot of surgeons of late. Maybe I would certainly take it with a pinch of salt, ma'am. I would not directly go. I would surely prefer surface ablation. But I think if your elevations are perfectly normal, front, back, and all your other parameters normal, decentered ablation is something which is sort of getting accepted today. And we ourselves have done quite a few of them, and all of them are surface ablations. And it's all dependent how big is your power, how much ablation you're doing. I think holistically, if you feel everything is perfect, I think we can go ahead just by ignoring that one single value of 1.5. So I don't think any thing will have a magic number. I think it's a holistic approach. But we have been doing medium to small power surface ablation when only this one parameter has been abnormal, with fortunately very stable corneas.
All of us being doing good number of refractive procedures, would you feel that we conclude this talk with saying that what could be the pachymetry values if your PTI is within normal levels? What should be the pachymetry values for flap-based procedures or smile procedures? Dr. Rajesh?
I wish I had the answer to this question. So for me, I don't have a perfect magic number, but I do look at the map qualitatively and quantitatively. And after assessing all the different parameters, I take into consideration. So I have treated surface ablation patients who are even 440, 450 with low myopic error. I have done a surface ablation. And at the same time, I have had patients who have sufficient corneal thickness, but because the map looks abnormal, I may have deferred the treatment. So I think it all depends on how you define what is normal and what is abnormal. So people should avoid the quantitative indices are basically as a guideline to raise red flags, but I don't think that these values are absolute numbers that you can go by and say that you are perfectly safe. But yes, anything less than 470 should definitely raise a red flag for surface ablation. If you want to do a LASIK, you have to take into consideration the amount of myopia or the refractive error that you're going to treat. So there you look at what kind of residual stromal bed or PTA value, how much change you're doing, and then you take a call, whether it's safe or whether you would like to choose another modality like a phakic IOL.
You would keep your cutoff as 470. I would have preferred to keep it 490 and below. I would look at surface only.
Yeah, in the sense, what I meant was that for 470 also, if somebody wants to do a surface ablation, less than 470, you really need to go and look at the map and then proceed with surface. But between 470 and 500, you are still safe because in the normal distribution of corneal thickness, the lower end, you will get normal patients with that kind of corneal thickness values.
You have any other question to ask in this very important topic, or do we move on?
Can I just?
Yes.
I think I would also look at the TBI and the CBI, especially in those cases which are suspects. And in case these are doubtful, then I think I would defer refractive surgery.
Yes.
Yes,
Can
that's
I also add a
point? If you have access to that, not only that, the other thing that in present time, I think looking at the epithelial maps is also nice because sometimes when you have an abnormal curvature, you can always look at the epithelium thickness map and then decide, whether that is creating that abnormality.
No, we would be talking about that because we have epithelial map coming up separately. Related to indices, anything further I like to add, Namrata, Dr. Merle, Dr. Radhika?
Just one point. Basically, when we think about smile, so the amount of ablation, not ablation, the amount of tissue that it takes off per diopter is actually higher than LASIK, and that's something that we have to keep in mind. Even if a cornea is thin, you have to consider that the amount that it's going to take away is more. So it works out to almost 20 microns per diopter. So the residual stromal bed is what we need to calculate, bearing this in mind. And we've looked at the data and found that it's ranging from 18 to 20 diopters. 18 to 20 microns per diopter, so you have to keep that in mind.
I have one point to add. That is a lot of in our country, a lot of patients coming are very young. They're often, just 20, 21. And if you have any abnormal parameters like this, it's also not a bad idea to watch them for some time, because it may be something which is evolving. So you explain to them that it is borderline, and then you watch them. So that's another thing I will just add. If in doubt, it's always better to explain. Otherwise, the patient doesn't understand and they keep shopping and going here and there. So it's better to explain that this is the situation and let's watch and see if it's stable.